like to introduce you to Melissa Hirsch, my colleague who is a senior PT at the Center for Musculoskeletal Care at NYU Langone Medical Center. She earned her doctorate in PT from the University of Scranton in 2000. And in the fall of 2011, Melissa completed her study of mechanical diagnosis and treatment and became a credentialed therapist in the McKenzie method. Her areas of specialty include working with injured runners of all levels of performance, as well as the management of spine dysfunction, and she plays an integral role as a member of the clinical running team at CMC. So we want to welcome Melissa. I also want to let you know that after Melissa's talk, we will have a panel of people come up for Q&A, so please feel free to prepare your questions, because there'll be members of the team from the Sports Performance Center as well as others to field your questions. Okay. At the end, if you'd like to give me these as well, I'd be happy to take them.
Thank you, Mia. Well, good evening, everybody. I'm very excited to be here. It's definitely an exciting time of year for runners, particularly in New York with the marathon coming up. So tonight we're going to be speaking about managing your running injuries as marathon day approaches. So what I hope to be able to accomplish tonight is to identify some of the more common injuries seen across the spectrum of the running population. To discuss some potential management strategies that you all can immediately integrate once you exit this room this evening, and learn to appreciate the value of your efforts in managing your injuries so that we can really minimize those aches and pains on the journey to the finish line. So as a therapist, I really have embraced the concept of earning the right to run pain-free. And to my patients and to the runners that I work with, I really like them to learn to take on the responsibility of self-management. And so let's think about, in an ideal runner's world, every step of every mile would be completely pain-free. But in reality, everybody has a little ache or a twinge. But those aches and twinges don't necessarily derail you. You're certainly not going to stop running. But there are certainly one or multiple nagging issues that serve to compromise the quality of your natural movement pattern. When pain comes into the equation, it really can serve to be pretty detrimental to your natural biomechanics and how you carry yourself when you're running. So those aches and pains, when do they typically come about? Usually when you start hitting the hills, when you change your pace, or when you just get tired. And so that's certainly not to say that you shouldn't be including hill running. That's definitely an important part of your training, but we're just identifying this as a junction in your training that pain typically sets in. So what do we do about the pain? Self-management. So I'd like you all to think of self-management as having two areas of awareness. Awareness of symptom fluctuation. So where, when, how often do you feel your symptoms? And awareness of gradual change in quality of movement and alignment. So that postural alignment, nice elongated posture that you might assume in mile 1, does that look the same at mile 5 or 6 or 17 or 18? So once you've identified the common threads in how and when your symptoms present, you can better than be able to figure out where on the spectrum of injury that you fall. So the top, the green zone, that's where everybody wants to be. They want to be pain-free, your performance is optimal, you're feeling really good in this zone. Down below, time off, you certainly should not be running. You certainly should be seeking the help of a physician. And in the yellow zone is typically where the most common injuries tend to fall. And so let's call this the not quite severely injured, but not so healthy zone. So is anybody in here in the yellow zone? So what can you do to stay in the green and out of the yellow? So this really depends on how you react when the first stab of pain hits. So let's talk about symptom fluctuation, and let's use the example of non-specific knee pain. So do you feel that knee pain immediately at the start of your run, or is it more like a few miles in? And what about when you're just on level ground or when you start hitting the hills? And then with regards to quality of movement and your alignment, do you notice yourself crouching down and assuming this rounded shoulder posture as you're trying to accomplish and conquer that incline? Or do you start to feel your knees start to touch as you get into mile 5 or 6 or 17 or 18? And so these characteristics can really be noted as inefficient and dysfunctional movement patterns. So there comes a point where you really can't assume that it's going to resolve on its own, because having this type of mentality really can pave the way for you to linger in that yellow zone. And the whole idea is that we remain in the green zone. And so let's consider this flipping the switch up top here and have more of a conscious effort to listen to your body and pay attention to those symptoms. So here they are, the big 7. The runner's knee or patellofemoral pain syndrome, Achilles tendonitis, hamstring issues, plantar fasciitis, the shin splints, that dreaded iliotibial band syndrome, and the stress fracture. So stress fracture is clearly a red zone injury. You should not be running with a stress fracture. But with regards to these injuries listed here, it really depends on the intensity. There's a spectrum of intensity of the symptoms that you feel. So just because you have plantar fasciitis doesn't mean that you're at the low end of the yellow zone. So obviously there's some differences there. So what causes the big 7? So there's been a common thread identified in the research that is really a potential underlying cause of most of your pain. And we know this to be the asymmetries in strength and movement pattern dysfunction amongst key muscle groups. And so what are those muscle groups? We know them to be the transversus abdominis and the gluteal muscles. And it's not only the fact that they're weak, it's the fact that there is a lack in the ability of these muscles to work together, to coordinate, to work as a team, and to recruit these movement patterns in a timely fashion. And with these sorts of deficits, the weakness and the poor coordination, this really can result really in the perfect storm for like a biomechanical high-risk behavior of your legs. So what we typically see across the spectrum of all 7, all the big 7 injuries are 2 specific biomechanical faults or malalignments. So the first is pelvic drop. And so on the left side of the screen here, you'll see that the line that transects the waistline, in a perfect world, that would be completely horizontal. So on the right side here is abnormal, and then on the runner there, you'll see that drop down to the opposite side of the standing limb. The second very common biomechanical fault, again seen typically throughout the big 7, is this kind of gapping inward of the knee on the standing limb, which can really create a poor alignment and poor distribution of forces throughout the limb and all the way up the kinetic chain to distribute forces that in areas that aren't necessarily used to handling those forces. So what do we do about it? This is what you guys have been waiting for. So remember, we have to earn the right to run pain-free, okay? These are the phase 1 exercises. We know these exercises to target those most relevant muscle groups, the transverse abdominis and the gluteal muscles. And I'd actually like to invite my colleague Colleen Bra, one of our clinical specialists here at CMC. We're going to do a little demonstration. So the first exercise on the top left of your screen is called the clamshell. So as you can see, Colleen is on her side. I'm going to ask her to pull her navel, her belly, up and inward. And she's going to lift and open up those knees, really engaging the gluteal muscles. So she's doing this in a nice controlled manner. Her body isn't rocking back and forth. And we're having the abdominal muscles and the gluteal muscles recruit and turn on at the same time to learn how to work together. Okay, so this is the clamshell. Next, we're going to go into the bridge exercise. So Colleen's feet are going to be just about hip width apart. She's going to lift her pelvis up nice and high, and at the peak of that range, she's going to squeeze her glutes together nice and tight, and at the same time draw her navel up and inward. So again, the same pattern, this co-contraction, this teamwork of the abdominals and the glutes working together. And she can hold that nice for a couple seconds at the top and control it as it goes down. And lastly, prone hip extension. So really just laying on her stomach. We're in this position really to calm down the muscles in the back, which can compensate in this movement. And she's going to kick her leg straight back, lifting up with her glutes and flexing her foot, driving her heel away from her. And at the top of that range, she's really going to try and squeeze her glute and hold that nice and tight as she's also drawing in her belly up and in. So, and there really doesn't necessarily have to be this excessive lifting or arching of the back. The height and the amount of movement that is required in this exercise is really minimal. It's really all about the quality and engaging that teamwork and co-contraction of the belly muscles and the glutes. Thanks, Colleen. It's called prone hip extension. Prone just means laying on your belly. So that brings us to phase 2. Both of these phases you're going to be doing for approximately a week and a half to 2 weeks. It's all the same theme. They're all accomplishing this co-contraction of the glutes and the abdominals working together. So on the top left, you have the side bridge. On the top right, you would be starting on your hands and knees and lifting the belly, lifting the opposite arm and the opposite limb at the same time, drawing in the navel and squeezing that glute right at the top there. And when you're kicking that leg out, flexing, bringing your toes towards your nose basically and pushing your heel away from you, really to get those glutes to activate. And lastly, the bridge walkout, or a bridge with a couple of steps forward. So you do the bridge, you take a couple of baby steps forward, a couple of baby steps backward, and lower your pelvis. And ideally, we want to create a nice neutral alignment there. Same theme, everything's working together. And lastly, we have phase 3. Now, Dr. Cardone had noted about doing some sort of warm-up. You could use the phase 3 exercises. You don't necessarily have to do these daily, but you really could do them just prior to your run. On the left side of the screen is the lateral step up, and on the right side is the star excursion exercise. So really, what is the point of all 3 of these phases? We're really trying to reestablish efficient patterns of movement so that eventually it all becomes second nature and we can avoid disproportionate amounts of force being translated up and down the line, so that areas that aren't used to taking that much force don't have to deal with it and then present itself as pain or one of the big 7. That's called the star excursion exercise. So this brings us to real-time training. So what we want to do is combine the newfound body awareness that you've all developed of your symptom fluctuation and your quality of movement and your alignment, and pair that together with the key muscle groups that you've just been working so hard on for the past few weeks and gotten them nice and strong, because we want to rewire the connection of how these muscle groups work together to maximize the overall effect so that we can really improve your alignment. And so some of you might be thinking, is there research to support these exercises having some direct carryover right into improving those 2 biomechanical faults that we identified? What we do know is that only doing the exercises is not enough. So we have to combine the exercises with particular cues while you're on your feet, while you're training, and have these 2 components work together. So the cues that we like to use are engaging your lower abdominals and your pelvic floor, again, pulling your belly up and in. You're going to be doing this for 2 minutes, and through each one of these, you're going to keep cycling through. Next, for the next 2 minutes, you can focus on that midfoot landing that Dr. Cardone mentioned, and a nice tall chest lift instead of crouching down forward with this rounded posture, which would particularly be difficult when you're trying to conquer that hill. Lastly, the glute push-off with a nice forward lean, ideally coming from the ankles, not necessarily from your hips, and trying to focus and cycle through for 2 minutes each with these cues, and ideally we can get some really nice results. So what did we learn tonight? So you've all hopefully adopted the concept of earning the right to run pain-free. And the way that we're going to do that is through self-management of awareness of your symptoms and the quality of your movement. We know that there is a typical weakness of the transverse abdominis and the gluteal muscles, and it's because of those weaknesses that we see these common malalignments of that pelvic drop and your knee gapping inward. And those 2 biomechanical faults, we see them throughout all of the big 7. And so what do we do about it? We integrate the phase 1 through 3 exercises. And we can't just do the exercises, we have to integrate the cues at the same time to hopefully have a much less painful run. So a wise colleague of mine once said, run those first 10 miles with your head, the next 10 miles with your legs, and the last 10K with your heart. So good luck and enjoy this running season.